This conference will now be recorded.
So welcome everybody to the 15th, yes, the 15th of December, high-risk recurrent advanced prostate cancer group. We got a full house and a couple of new guys. And we have one question in the box that I do want to answer very quickly. And it's a question from Dr. Mark about bispecific. Help me out again. I always forget what the
They're bispecific T-cell engagers.
Bispecific T-cell engagers. Thank you. I got to tell you, Mark, I don't know the difference, and there's about 5 or 6 of them that are out there. But I can tell you what I've done about it. After I listened to Dr. Morgan's interviewing Dr. Sartor and Dr. Tran a couple of weeks ago, about 10 days ago, I wrote Dr. Morgan's and I asked that they put together a webinar in the new year explaining the difference between the ones I listed, and I knew there were more, like I did not list AR110, I listed AMG 160, AMG 509, the Regeneron one, the Xencor one, and I think one other, and there's more. So I cannot tell you how one differentiates from the other. I guess I'll defer to Len or to Herb. Do you know what the difference is between these various engagers?
Yes. So what a bispecific T-cell engager has 3 parts. One is an antibody directed, or a piece of an antibody, the recognition site, directed against a tumor antigen. That's one part. The second part is called a linker. And then the third part is an antibody or piece of an antibody against an antigen on T cells, most often what's called CD3, which is on active T cells. And so the whole thought of using these BiTEs is that one end of the antibody is going to hook on to the tumor antigen and then bring the T cell through, because it's also attached to CD3 at the T cell, into the tumor, and they will engage each other in battle. And by being up close, the T cells are then supposed to expand, as they do when they meet their antigen, and have anti-tumor activity. The differences are in all 3 of those things. What's the tumor antigen? So many of them have PSMA, but there are others in prostate that also are targets. And I'm not going to differentiate which company. Second is, what's the linker? The third is that, for example, these are all recombinant proteins. If you inject them in the body, they get eaten up and chewed up. So they've also, some of the companies have added on side proteins, which essentially keep the BiTEs longer in circulation, because the original BiTE from Amgen lasted 30 minutes. That wasn't really long enough to do anything. So they added on a little tag which will slow down metabolism. So really it's a very simple concept. One side targets a T cell, the other side targets a tumor antigen. And I saw a very informative webinar from Amgen, and basically they're doing this for every cancer possible. It's not just prostate. They've had some success in more, not so much in solid tumors, but they really are gung-ho with their BiTE program. And if there are any other questions, I think either Len or I can answer them.
Herb, do you know if, I mean, it's the same as the lutetium-177, where you have the linker and you're linking PSMA to lutetium, but here you're doing it to attract and bring immune cells and CD3 cells in. Does it bypass the PD-1, PD-L1 blockade?
No, that's my major criticism. And to be honest, I was going to write to the person who did the webinar and say, what are you going to do? I mean, so here's the difference is that when the T cells expand and they attack a tumor, there's two issues that this comes out of the CAR T program. Number one, there are these things called checkpoints, and the T cells get stopped by tumor checkpoints. So that's why, there are these things called checkpoint inhibitors, CTLA4, anti-CTLA4 is one, for example, and that they haven't dealt with that. The other that they haven't dealt with is the process of exhaustion. Even after the T cells expand and do their job, they disappear. So there's something that's got to keep them in and busy. And the other people are approaching both of those with other methods, but I have not seen anybody that's doing that in combination.
One more thing, the AR-110 is totally different.
Let me cut you off, Mark, because we just saved that one for next week. We'll talk about AR-110 next week, but we've just got too many people now to keep going here. But it's a great question. I'm not dismissing the question. We just cannot deal with it this week. Is that okay by you, Dr. Mark? Thanks. Okay, so we're going to get started with the two new men. What we usually ask you to do is to tell us a little bit about your background, how old you are, where you live, who's treating you, where you are in the disease, and whether you've got any specific questions for the group. The other thing, just some housekeeping here. There is a little bubble in the top on the right, which opens a chat window, and we've already got a lot of action in that chat window. You'll find people put in questions, links. You can click on the link in there, it'll open up in your browser, and other things. We would ask you new fellas, if you don't mind, to send us your emails, provide us your emails in that chat window. You don't have to send them to everybody if you don't want. You can just send them to me, send it to Rick, and then we'll enter you, and you'll be sure to get a reminder next week. So that's just a bit of housekeeping there. All right, who would like to go first, Terry or Vern?
This is Vern. I'll go ahead and go first.
Thank you, Vern.
In 2007, my PSA went up, and so I had a biopsy and a prostatectomy, and everything was great till 2014. The PSA started rising, and I had the 40 days of radiation. That lasted for a year, and then I went on Zytiga, prednisone, and Lupron for 1 year, stopped it in June of 2019. Everything was fine until 2 months ago. The PSA rose again. So I elected to go to UCLA for a PSMA scan, which I finished last week. And that shows mets and the lymph nodes near the neck and in the back and all over. So right now I'm debating about what to do. I probably am still hormone sensitive, so I'm not really eligible for the lutetium-177 and some of the other treatments, but that's right now I'm just researching all the options.
Okay, so let me just clarify a little bit. 2007 you were diagnosed, 2014 you had IMRT. When did your PSA start to rise?
After that, it started. Yeah, it started to rise in early 2018 or 2018. And so the middle of 2018, I went on the Zytiga lupron prednisone
Right.
for 1 year.
And are you still on Zytiga and prednisone and Lupron?
I stopped that after 1 year. So I stopped that. And the side effects were pretty heavy. So I elected to stop after 1 year.
Yeah, you know, it affects different guys different ways. The guys will tell you that because there are some on it and some not on this call. And so you're on nothing right now?
Correct.
And what was your original Gleason score?
It was 4 + 3.
4 + 3. And did you have anything unusual like seminal vesicle invasion or perineural invasion or extracapular extension that they noted on the biopsy or anything like that?
Yeah, they said that all the margins were negative, but there was some extra capillary extension. So
ECE, okay. But you didn't do, you said you did surgery. Did you do, sorry, you said you did radiation therapy in 2014. In 2007, did you do surgery? I missed that.
yes, only surgery, correct.
Oh, okay. So you did an RP back in 2007. That was when I got diagnosed. Wow. And where did you have that done, Vern?
At Tucson Medical Center.
Uh-huh. I'm in Tubac.
Oh, okay.
So you had it done at TMC, and your follow-up, I mean, who's been prescribing the Zytiga and the prednisone and the Zytiga and the Lupron to you?
Yeah, I have a urologist that seems fairly knowledgeable that I'm using, Dr. Dunge.
All right. Well, we'll talk to you about that. Dennis Correa, who's also local, will talk to you about that momentarily. And one last question before I throw it open, which is, give us some idea of your PSA. When you were first diagnosed, what was your PSA like?
You know, I've lost the records, but I think it was about 6. It wasn't terrible. And
Okay.
then when it came back, and I had radiation, it got up to like 5. And before I started the Zytiga Lupron, it was only like 2.5.
And what is it
right now? It's 2.
What is it right now?
2.
2, did you say?
Yes.
Okay. Well, let's kick off with Dennis Correa, who lives up in Oro Valley, and is pretty familiar with the prostate cancer care in the Tucson area. And Dennis, why don't you give your thoughts to and start off with your thoughts for Vern.
Okay, hi Vern. Welcome to our group here. Hope we can be of beneficial use to you. I'm actually in Marana, Rick, not Oro Valley, but
sorry.
Okay. And I am working with 2 oncologists. One that I started with in Tucson, who moved to Mayo up in Scottsdale, Phoenix. Dr. Parminder Singh, who is a GU medical oncologist, who we always refer our newcomers that have not yet been working or have a lead person for their prostate cancer. And he used to be with the U of A, and that's where I started with him, and he moved. And then I have another local oncologist and medical oncologist. He doesn't totally specialize in prostate cancer. He does breast cancer and some other things here. But he's also very good. And he is with the Arizona Blood and Cancer office locally here in Tucson. And that's where I go to get my 3-month exams and my blood work. So it's very convenient. And when I have an issue, I can get in touch with Dr. Sang up at Mayo, and he takes me in there and we do what we need to do. The local oncologist is Shamaddin Rafiat, and he's at the, let's see, Arizona Blood and Cancer off of Arvinas in Tucson.
No, thank you, Dennis. So I think the message really is that at this point in time, you probably should have moved on from your urologist. And I'll let some other guys in the call say something about that, but you are sort of beyond the pay level of the urologist, and the treatment that you're going to engage next really should be under the supervision of a medical oncologist, and not just any medical oncologist, but a medical oncologist who specializes in prostate cancer. It's really, really important, and we'll take another 5 or 10 minutes max to try and drive that point home for you, Vern, because there are guys on this call who did not have a medical oncologist on their team until they joined this group, and then have now incorporated one and really see a difference in the approach. Is there somebody who'd like to talk to Vern about the importance of having a medical oncologist on your team? A GU med-onc. Don't all shout at once.
I can make a quick comment on that. I was one of those guys that was working with a urologist, and these guys beat me over the head about it and made me go see a medical oncologist specializing in prostate down at Yale. And it suited me much better because I wanted an aggressive treatment, and I was tired of everybody taking so much time to get around to treatments. And so I feel a lot better about my treatment, and that, you know, they're not going to fool around. They're going to really go for it.
Thanks, John. Anybody else want to say anything about involving a GU med-onc versus a urologist or a general med-onc? Yes, John. John Ivory.
I'm not a huge sports fan, but Wayne Gretzky used to say, skate to where the puck is going rather than where the puck has been. And I too stayed with a urologist too long before. I had the same thing where I did surgery, and then I did radiation, and then I did hormone treatment. And in my mind, I should have jumped to the radiologist, and I think I got radiology a little, or I'm sorry, radiation, not radiology, a little later than I would have liked, because my urologist, you know, thought it was fine to stay. But then after my PSA started going up after my radiation, then I realized right away that I needed to go someone that really understood a systemic treatment rather than a local treatment. I happened to choose UR med-onc the first time just because I was looking for experts in prostate cancer, but I think it's really made a difference. And from chatting with the people on this call as well, you want someone that spends all of their day thinking through the latest research that's not only FDA approved, but that's in clinical trials and coming up. So same thing as I said at the beginning, you want to skate where the puck is going, not where the puck has been.
Vern, what is your, have you reviewed the PSMA results with any of your medical team, and what are they suggesting to you?
The urologist suggested that I had two choices. One is just wait until something creates pain and we can go deal with it, or to go back on Zytiga, prednisone, and Lupron. That was his choice, which I think there's more choices than that out there, and that's one of the reasons I'm listening to all you folks. And yeah, and I really appreciate the comment on the oncologist. I did go to two of them at the University of Arizona, and both of them were extremely disappointing. in their approach to aggressive treatment. So
Yeah, I'd seen, yeah, that's not the first time we've heard that, and I'd seen the same thing. And really, I think we'd send you up to either Alan Bryce, who is the head of the group and really good, BRYCE at Mayo, or Parminder Singh, who Dennis Correa mentioned. But you can't really go wrong with either of them. So those are two names for you at Mayo who are GU med oncs. Those are probably the two best options in Phoenix right now. Alan Bryce, BRYCE, or Parminder Singh. Len, would you like to maybe just talk very quickly about what sort of treatment options are available when you've got recurrent lymph nodes, since that's a subject you know a lot about?
Well, certainly there's something they call MDT, metastasis-directed therapy, where they can do spot radiation on the lymph nodes, on the recurrent lymph nodes. There's a lot of controversy about whether or not that is effective, but that is one option. Have you been scanned recently, Vern, to make sure you don't have any metastasis beyond the lymph nodes, any bone metastases?
yes, I had a PSMA scan last week at UCLA, and it showed no involvement of anything in the bones, but several different lymph nodes.
And were they all regional pelvic lymph nodes, or were there any distant lymph nodes?
There were distant ones, clavicle, supraclavicle lymph nodes, and a couple other ones. I'm sorry, I don't recall.
Okay,
exactly
so, well, you know, this is something you need to talk about with when you get to see a GU medical oncologist who can from there send you off possibly to a radiation oncologist to discuss spot radiation. But I suspect with the number of lymph nodes involved and the distance they are from the pelvic region, that's probably not a good option for you. So some form of systemic therapy, whether it be chemotherapy or continued hormone therapy, since I believe you said, well, even though you stopped Zytiga, you were still hormone sensitive. Is that right?
Yes, and as far as I know, I still am.
Right. So either chemotherapy or continuing or hormone therapy might be your best options. But again, you know, these are things you need to talk over with a competent GU medical oncologist, preferably at a comprehensive cancer center, what we call an NCCN hospital.
Yeah, I mean, I think in Tucson, Len, you're kind of restricted, so it will probably be at Mayo Clinic. And I don't think the Phoenix is an NCCN, but it's certainly a good hospital. Vern, how old are you? You didn't tell us.
Oh, I'm sorry, I'm 78.
78. So, you know, that also may be a consideration. Look, it may well be that the GU Med-Onc comes to the same conclusion as the local urologist. But, you know, one of the issues that we find is that the local urologists really don't do a great job taking care of the side effects. And you've already suffered from some of the side effects, and they don't because they're not trained in internal medicine. And so if you've got side effects and you need help, then your medical oncologist, your genitourinary medical oncologist, is going to be in a much better place. I think, is there anybody else that would like to say anything at all to Vern before we move on? Yes, Herb.
Well, one quick question. I mean, what kind of the side effects were you getting with Zytiga and prednisone that made you stop?
It was the hot flashes. They were like a day, and then during the night every 2 hours, almost I could set my watch by it. Gynecomastia, certainly gaining a lot of weight around the center, weakness, mental fog. I'm probably forgetting some, but there were just a slew. Nothing that, I mean, that's what it is. It's okay, but it's just, it was pretty nasty.
Were you doing any exercise, Vern? Did you have a regular exercise routine?
I didn't have a regular exercise routine. In the summer, I did a lot of fly fishing and walking, but during the winter, it was,
Yeah.
no, I didn't do as much as I should have.
I think, and we will talk about this in the balance of the call because Regina wants to bring it up. But I think you'll find that if you can incorporate a more vigorous daily exercise routine, you're going to alleviate some of those side effects. Not completely, and not all of them, but they are fairly common. The other thing is that you may do better. We've got gents on this call who couldn't tolerate abiraterone, who couldn't tolerate enzalutamide, but are tolerating abiraterone very well. You may be a guy who tolerates abiraterone poorly, but you do better on enzalutamide. So, you know, there are options there. And these are the sorts of things that a genitourinary medical oncologist is going to be more familiar with and be able to find something for you. And I will also say, there are some mitigants to all of these side effects, but I'm afraid in the interest of time, I've got to move on to the other new guy, bearing in mind all the other, we could keep talking to you for another 20 minutes, but I hope you'll come back. Please provide us your email. Maybe we can connect you to Dennis somehow or the other. Dennis, maybe you can send Vern your contact details in the chat window, directly in the chat window, and and you should feel free to give me a call if you have any questions. I'll put my telephone number in the chat window right now. Anything that you would like to ask us before we move on to Terry?
No, thanks so much for the input.
Pleasure. Terry, you got the program now. You know what to do. We don't have to tell you anything, man. So go for it, and you got about 20 minutes.
Oh my goodness, 20 minutes. Well, Vern, actually, it was very informative to hear your story, so thank you. I'm kind of at the beginning of the path, I think, where you're at, is I was told a year ago, October 28th, that I had a 28 PSA. Well, 3 years prior to that, I had a completely normal PSA. Oh, I'm 61 right now.
Thank you.
I live in Portland, although I recently moved here, broke up with the woman I was with for 16 years, and that's a whole nother story. No, I'm in Portland. I'm really in the good hands of a really good team here at OHSU, and I really like my urologist. And so I had this 28 PSA, and with COVID and various other factors tumbled into it, I didn't have the prostatectomy until July, the end of July. I also, on the CAT scans, they found cancer on kidney, and so they took that out at the same time, because I'm like, I don't feel like recovering from 2 surgeries this year. So that was we just went ahead and did that. Had some complications afterwards, and ended up having an infection and peritoneal fluid buildup in my abdominal cavity. And so when I recovered from that, and I'm feeling good, and I'm out back getting doing a little bit of work, and they got me in for another scan, and they're in another PSA. My PSA, they wanted to have, my urologist was hoping to see none detected, and it was 1.1. And so they ordered the other more advanced scan, and I think it was, well, I don't know if it was the PSMA or they had just approved that weeks ago, just a week or two ago, didn't they?
Yeah.
Okay, yeah, it was, yeah, he was talking about the PSMA one. So he's like, anyway, they found that the cancer has spread onto my pelvic floor and the lymph glands. So I got referred to a medical oncologist and a radiology oncologist there in OHSU, and worked in tandem with a really great team with the oncology nurse navigator and everything. I mean, they're fantastic there. But I had another PSA done shortly, just then another month after that 1.1, and it was 2.1. And I had gotten my PSA to go down with some alternative therapy between the 28 and getting surgery. I got it down to 19, just changing lifestyle habits and consuming RSO. Just while while I was waiting for the surgery. So I've resumed an RSO regimen while I'm awaiting my decision what the hell to do next, because after speaking with a second opinion oncologist, because I didn't really care for the first one, the first one wanted really aggressive 6-month hormone deprivation therapy, and then hit it with the radiation after it shrunk down. And I hear that, but after reading the side effects, hearing burn and and other such stories, I don't know if I want to lock in the 6 months of whatever it is. And going to be like when I got speaking with the second oncologist, she was much more had a different approach, and she was like, we can do a week and see how it feels, and then like like you guys were saying, Rick was saying, I think Rick, well, you work a different hormone if it doesn't work for you, and see if that one works with your system better. And you know, I'm hoping to be able to suffer through the androgen deprivation therapy for 6 months, or it's going to be longer than 6 months, I'm sure, because of how aggressive they say it is. I'm just not looking forward to it. And then I hear guys' stories and I'm like, man, I've lived a good life, even though, you know, I'm pretty young, but like, do I want to go through all that, or do I just want to live my life?
So let me jump in a little bit in the interest of time, and a couple of, and that's very helpful what you've told us. We've got a good picture. A couple of questions. What was your original Gleason score in your original PSA?
27.8 or something of that.
Right.
27, very high, very high.
Yeah.
Yeah.
And the Gleason?
7, 4, 3.
4 plus 3. Who are the genitourinary medical oncologists you've seen so far at OHSU?
I saw Dr. Tiramali, and I saw Dr. Vicky, of course, on Zoom meetings like this. But yeah, Dr. Vicky, and I like Dr. Vicky, and they're both good, you know. But I I felt I had a better feel from Dr. Vicky.
Yeah, so we know somebody else with Dr. Buki, and he seems to like her a lot.
Yeah.
You know, I think the news that unfortunately somebody has to break to you, and it may as well be us, because we're the easiest ones to fire, is that you're probably going to be on enough hormone therapy for the rest of your life. So,
Right. Yeah. Do I want that? Because it affords me what, 5, 10, 5, 7 extra years?
that's we don't know. We've
Right.
got guys who have been on hormone therapy for 15 years or more, 20 years. But the art now, Terry, is that you've got to manage this disease, and there are a lot of ways to manage it. And the more aggressive you are now, the easier it's going to be to manage this disease for the longest period of time, and the better the chance that you can do what's called intermittent therapy, where you get on and then you get off for a while, and then you get on and you get off. And we've got guys on this call who have been doing that for years.
Okay.
But if you mess around now, it's a bigger issue.
Okay.
It could be a bigger issue. Now, we're not here to give you medical advice. We're here to tell you what your options are, what to ask your docs. And your story, unfortunately, is not that uncommon. You mentioned, I'm just curious, you mentioned that your PSA was 28 in October 19. How often were you checking your PSA before that?
Oh, before it was, I went back and checked. It looked like they were doing it every 3 years.
Yeah. And, you know, this is one of the problems, that it can creep up on you. It did the same thing to me. And because we don't check our PSA regularly enough, for a lot of reasons I'm not going to get into now, and then all of a sudden it's gone too far, and then you're behind the 8 ball and you're fighting. So let's open this up to some people on the call who I'm sure have got words of comfort for you, and I think you'll find over the next few months and years are going to be a great support. Dr. Mark, why don't you kick off?
I started it. First month was horrible. It was like my wife said, all my patients who I'd prescribed Lupron to were getting back at me. We added this Zytiga, and after a month of hearing Rick tell me to exercise, I got bands, I got dumbbells, and on the days that I do that, I don't have the hot flashes. I feel like I have energy. I do it first thing in the morning rather than throughout the day, but sometimes while watching TV, I'll do it again.
Yeah.
Right now, I mean, I wouldn't want to do brain surgery now, but I feel pretty good and able to do most stuff. And if the Zytiga is a problem, you have enzalutamide, apalutamide, darolutamide may be better if you're having a lot of brain fog because it doesn't cross the blood-brain barrier. But there are a lot of different options here. And giving up, I don't think is the right thing at this stage, because you can live with this. Your body adjusts to the ADT symptoms. That's all I wanted to say.
Herb.
So yeah, I'll follow up with Mark. I mean, I'm on the same drugs. And Mark, I did brain surgery last week, only it was on a mouse. So you can do brain surgery on ADT. And, you know, when I first was diagnosed, and it was already metastatic, and my medical oncologist said to me, look, our goal is to make this a chronic condition. And I think that's what we're all facing, that this is going to be a chronic condition. It's not one we all signed up for, but you do what you can to make it chronic. And I agree. You know, I do stationary bike every morning. I do exercise, and the hot flashes, I have to admit, the cold weather has even helped. It was worse during the summer, and now it's not so bad. But I think it's something that you'll just grow to tolerate because that's part of the game. And I think it's something, you know, your medical oncologists are going to tell you this.
Bob McHugh, go ahead.
I was quickly, I've had 3 courses, 3 6-month courses of ADT, Zoladex all 3 times. I was terrified to go on that. I went to see a psychiatrist before I did anything else. You don't need to be that scared, Terry. I'm here. We're here for you. You do not need to be that scared. It's not that bad.
Okay.
Thanks.
All right, guys.
Who else? Oh, Jim Barnes, Jim B, go ahead.
Hi, Terry. I joined the group back in on August 5th, and then I had the exact same concern you had about the ADT, and since then I've been on. I've had my second round of Eligard, which is an ADT, and then I've been on Xtandi for a month and a half now on top of the Eligard, and I got on here. Unfortunately, these guys, people like Herb, told me early on, is like, don't worry about it. He exercises every day, and you get through it, and it's not that bad. And I would have to say that rang true for me. So these guys and their experiences had a big impact on my. Because I was so concerned. I was like, no way am I getting on ADT. And but it's really not that bad. So just wanted to pass that along to you. And that's part of the benefit of this group here, is seeing these guys. Everybody's healthy and talking, and it seems like they're living happy lives and fulfilling lives and everything else. And just it's just a matter of managing things moving forward.
Thanks.
I just want to add one more thing.
Thanks,
and that, Peter, I'll say it in a minute. So, by the way, I don't know how many of you know that Religolics was approved by the FDA.
What?
That is an oral.
Oh, it was?
Yes.
When was it approved?
So that was very recent.
I didn't see that. Yeah, that's the Myovant drug. We worked a little bit with Myovant, but it's not, I don't know who it's going to be available for and whether the insurance will pay for it, but let's not digress on that for,
Okay.
go ahead.
Well, but it's not an injection. It's
Right,
much more controlled.
right. So Peter, go ahead. Peter K.
Yeah, so I'm 6.5 years into this, and I've been on and off androgen deprivation for 6.5 years. I'm on now. It's not, we all react very differently. I've never had hot flashes in all that time. Looking at it like it's a temporary, like you might get an extra 5 years of life out of it. That's not the way to look at it. It's a management tool, and you might go very, very long with this thing. On the plus side, I'm not saying this facetiously, but a little bit facetiously. It's probably, if you're going to go on androgen deprivation, it's probably a good thing that you broke up with your girlfriend at this point, because that's one of the heavy parts, is trying to get your partner to understand what you're going through. It's not easy because it takes an emotional toll on you. But once you get used to it, and once you get into the rhythm, you'll be on top of it, and it's pretty clear sailing. I mean, I'm walking 3 or 4 miles a day at a good clip, doing yoga. I don't even think about it much anymore. I'm just, I'm taking naps. I'm sailing pretty on top of the waves here, so it doesn't bother me. So don't get nervous. Don't get scared. It's a management tool and very useful.
Okay. Thanks, Peter.
So Terry, you've heard a few guys give you some feedback. I hope that we've opened your mind a little bit to considering some form of hormone therapy.
Yeah.
Go ahead.
I have been, I've been leaning that direction. I just waffle in my thoughts about it. But my medical oncologist, she's given me a little latitude to be like, well, we're going to see what your PSA is in another month, and then you can make your decision what you're doing. And that'll be in about 3 weeks. I'm going to be going to get my next PSA, and no doubt I'll be starting my hormone therapy the next week after. So the beginning of January is what I'm going to start a trial run with a 1 week or a month dose to see if I tolerate it well before I nail down which hormone therapy to submit me. Yeah.
Well,
You're gonna have to let it go for 2 months before you see what it's like. 1 week doesn't tell you anything.
I see.
2 months minimum will let you know how you're doing with it.
Okay, Peter. Okay, yeah. I'll definitely talk with my my oncologist. She's already kind of laid out a plan, which A, B, and C, three different plans. The full meal deal, as she calls it, the pick and choose meal, or we're gonna just do maintenance on you. But I think I'm gonna go with the middle of the road here, and see where it goes and what my numbers happen. And
let me suggest you, Terry.
My physical therapist has been going real well. And two, she's been telling me start exercising more. I got to up it from 1-2 miles a day to the 3-4, and kick in something yoga or Tai Chi with that.
Well, let me just suggest a couple of things to you. First of all, with the exercise, and we're going to spend a few minutes on that. The key is really getting your heart rate up. You've got to get your heart rate up. So, if you wander around 2 miles at a gentle pace, it's not the same as you doing that same 2 miles at a fast clip. You do that 2 miles at a fast clip and you get your heart rate up for 15 or 20 minutes. That's good. So it isn't so much the distance, it's the effort that you put into it. And you can do that on a stationary bike, you can do it on a rowing machine, but again, we'll come back to that momentarily. Secondly, we don't have the time this week, but maybe you'll come back to our next meeting next Monday and tell us what these outlines are, these options are. Write them down and give us the options, because we can maybe help you a little bit in thinking through these hormone therapy options. For you, it doesn't mean much. For us, it's going to mean an awful lot more. And we'll be a good sounding board for those 3 options for you, and the pros and cons of each of the 3 options. The likelihood is the first injection they give you is probably going to be a 1-month injection, and it will probably not require any other drugs. And then at the end of that, you'll have to switch onto something else. And we can talk you and explain that to you again. Now isn't the best time. So just to sum up, keep an open mind to the ADT. We'll get you through it. Our goal is you're probably going to have to spend at least 18 months on it the first time around, but maybe at the end of 18 months to 2 years, you may get a break. We've got guys who have very similar diagnoses to yours who are just looking at taking a break now, and that's the idea. Mark Perloe, Dr. Mark has put something in about sexual rehab, which is really important, but again, it's in the chat window, you'll see it. Again, we don't have the time right now to get into it, but put it on your list to ask us about. We'll work with you on that. And last of all, make sure we've got your email. So
okay.
Send it to me, because then we'll put you on the list and you'll get a reminder for next Monday's meeting. So I've got to move on. Otherwise, people are going to be on my case again about not giving enough time to you existing guys. We've only got 55 minutes today. I do want to say one quick thing before we go, before we start on the list. Most of you who are regulars know that we never come to you asking for money, except there's always a but or an except in the month of December, which is when we have our annual campaign. And hopefully most of you received that annual campaign letter on Sunday. Some of you may not have read it yet. It's probably worth a read because we review what we've done in the last year, and what we have done in the last year is pretty spectacular for prostate cancer, as well as for a bunch of other conditions. Everything we do is pretty much volunteer. We've got almost 70 volunteers that make ANCAN work. We've got one paid person right now, only because I just couldn't do it anymore. I didn't have the bandwidth anymore, and I needed somebody to take some of the daily routine off my shoulders, but I don't get paid. So please, if you have an end of year giving plan, an end of year charitable plan, just please consider including us in that plan. That's all I'm going to say. All right. Let's try and we'll get through as many of you as we can. If we don't, feel free to come back to me. No charge. I won't ask you for a donation because it's one-on-one. If we didn't get you, we will we'll try and take care of you between now and next week, or else next Monday. All right, Les.
Okay, I just have a quick question. How long does it take before the side effects of Eligard, et cetera, are supposed to kick in? You know, I was on it originally back in 2013, and it hit me really hard, and also on Lupron. But I don't remember how long it took to kick in. This time I got my Eligard after being off of anything for year and a half or 2 years. I got my first Eligard again December 2nd, and I've had more endurance than I've had for the last 7 years so far.
Well, that's probably because, how long were you off, by the way?
I think it was about a year and a half or 2 years. I had it written down, but I can't remember.
And who gave the instructions to put you back on Eligard?
Your friend, Dr. Kwan.
Yeah. Well, Dr. Kwan should, I'm sorry, but I can't stop myself. Dr. Kwan should know better. Did he put you on bicalutamide first?
No.
Right. I marvel. I marvel. I mean, it's for your safety. We don't exactly know where the cancer is. Maybe there's cancer that he can't see. He's relying on his C10 scan. And the reason men are put on bicalutamide is because it's a buffer, because we don't know exactly where the cancer is. And what happens when you take Eligard is that it pushes your testosterone up before it drops. And what you're feeling right now is the push up, which will happen for maybe a couple of weeks. And then what the way it works is it overworks the testes and the pituitary, and they say, we can't keep up with this. We can't keep up with this stimulation. We're switching off. And that's when your testosterone starts to fall. And the reason we put people, I shouldn't say we, but the reason people are put on bicalutamide is, God forbid there's any adverse effects from the Eligard. Now, if you go on an antagonist, which is what we were just talking about with Terry, like Firmagon, Degarelix, you don't have to worry about that. But if you've been off for a year and a half and you've got a history of metastatic cancer, I don't get how it doesn't make sense to me that he doesn't put you on bicalutamide for 10 days first.
Well, that's what I was wondering about. The first time I went on Eligard, I was on Firmagon first, and that's what I was kind of questioning if, because I have gone through this route before, if there was not a need to do it again when I'm going on Eligard, again.
Well, the reason you're feeling great is because you've got a lot of testosterone in your system right now. How long will it be before it tails off? Probably Dr. Mark's the best person to ask for that. What would you say, Dr. Mark?
And you'll see the flare somewhere between 4 and 7 days in gonadotropins, but I'm not sure how long that will keep the testosterone up. If you give Lupron and Firmagon at the same time, you will still get the flare in gonadotropins and raise your testosterone. So when you're giving bicalutamide, or obviously the cost for enzalutamide, darolutamide are outrageous, or Zytiga for that matter, you could temporarily block production during that week or so. I would think it would be about a week to 10 days before the testosterone would plummet again.
Okay, this is what I was wondering, if it is that kick, but I was wondering if, because I had been before a couple of times, if it was not needed or it didn't make a difference, if I would not get this kick. But from what's been said, you'll get it anyway if you've been off for a while. That answered my question.
Thanks. Anybody else want to comment on that before we move on?
Well, Les, the Firmagon, of course, doesn't need a bicalutamide lead-in because it's a direct antagonist. So you said you had Firmagon, earlier, so you wouldn't have felt that testosterone surge on Firmagon.
But you will if you change over to Eligard a month later. So it's only during the time when you're taking the Firmagon that it's blocking the effect. If you go to an agonist later on, you'll still get that blast of testosterone.
Okay.
Oh, all right. We'll move on, and Bob McHugh back from last week. Oh, let me check. Jimmy Greenfield, can we hear you? Call in, man. We put the hold on, can we hear you? Sorry. Cannot hear you. Call in. Use the telephone and call in, and we'll hear your voice. Bob McHugh, what's your question?
I'd like to know if anybody has had any experience with radiation cystitis.
Well, I have. I think it was about 3 years after my radiation, and it was never that painful, but I noticed the bleeding. I went back. It happened, I think, 3 times. So I didn't bother my urologist the first time, and then nor the second time. Then I went to see him. I said, Joe, I think I've got an issue here. And he said, well, next time come in and we'll do a cystoscopy. And we did, and everything was fine. And it was just a little radiation cystitis. So it was easy. And now anytime, and I'm 13 years out, and still occasionally I'll see a little bit of blood in, and it doesn't bother me. I usually, if it's really bright, I know that it's the radiation cystitis. If it's pinkish, I know that it's probably, maybe from exercise, from my kidneys or something. Oh, that reminds me. Terry K. Sorry to come off. Terry, you said you had a kidney. they removed your kidney. Was that kidney cancer or was it a
Yeah.
metastasis from something
That-
else?
It was kidney cancer. The periphery did not have it in it, fortunately.
Right.
So
Okay.
it's
Yeah, I
it's
meant,
kind of no, so it's a mute issue, I hope, at this
Yeah.
point.
yeah. So that's anyone else have any input on radiation cystitis? Anyone else had radiation cystitis other than Bob and myself?
What is radiation cystitis?
So when you are radiated, it causes the tissue to become inflamed in the areas where you were radiated. And sometimes that inflammation can lead to a little bleeding. And most often for us prostate cancer patients who have had a lot of radiation, we have radiation proctitis, which means that we have radiation in the area of the rectum and the anus. And I think there's a bunch of guys who suffer from that on this call. I certainly do. Radiation cystitis is when it's the urethra that's been inflamed, and so you have blood in your urethra which you pee out. Is that I'm not much of a doc. I should have left that one to Dr. Mark. Sorry, Dr. Mark. I'm practicing without a license again.
Yeah, I'm sending you an honorary one in the mail.
Okay, thank you. Anybody want to add anything on radiation cystitis?
This is Les. I had bleeding in the urine for a while, and then later on from the rectum, and both were from that cause. And that was what we had talked on this line here before about. That's when doctor had given me then pentoxifylline, and that supposedly helped the situation.
Did you have any discomfort from the radiation cystitis, Les?
How was that again?
Did you have any discomfort from the radiation cystitis?
Not really, no. It just had bothered me that having blood in the urine or blood in the stool.
Yeah.
I need to interrupt here. If you are not using your microphone yourself, especially you, Bob McHugh, you're getting a lot of feedback from you. Very annoying.
Okay, but leave it on for the second, Bob. Any follow-up questions?
Yeah, I don't know where the feedback would be coming from, but I'll turn my mic off right away after I finish, which is just going to be quickly. I've never had any gross hematuria, which is what you're talking about, Peter, red blood in your urine. I have microscopic hematuria, which you can't see. But my symptoms are mimic a UTI, frequency and burning. And there are some drugs that I've tried unsuccessfully. And apparently the new state-of-the-art treatment for this condition, which my doctor, my med-onc, described as getting a sunburn on my bladder, to use medical terminology, is, believe it or not, hyperbaric oxygen. Yeah. With that, I'll turn my mic off.
Okay, so the one issue with hyperbaric chambers that they don't talk to you about, and we've actually seen this happen, is it can damage your retina. And so you have to really drill down. And if you've got any eye issues, they can really be exacerbated. And we know that from experience. I never, like I say, my radiation cystitis never got to that point where I had burning. Or, I mean, yeah, it's occasional burning. I mean, I still do. I usually figure when I get that, it's related to a stone, to be honest. But it could be the radiation cystitis. I never thought about that. Could be the radiation cystitis flaring up. But it usually lasts a week, 2 weeks, and then it goes away. And since I know what it is, it doesn't bother me. But if you've got continuous discomfort, you're doing the right thing. and probably should be talking to the urologist on that one rather than the medical oncologist. Okay. That's what I mean. That's certainly what I would do if my radiation cystitis came back. I'd be looking to speak to a radiation urologist. Okay. Can we close this one? Anybody else have anything before we move on? Okay. All right, Carl. You beat me into submission. You're up.
But wait a second, it's not 8 o'clock yet.
That's what I'm saying. You beat me into submission, man.
Okay, so I wanted to talk about my ongoing quest for PSMA scan. I am scheduled for an Axumin scan in 2 days, and those of you who are on the East Coast know that there's a snowstorm that we're expecting to have Wednesday into Thursday morning. So I hope I still will have the Axumin scan on Thursday. That scan is being done for several reasons, and one in particular is that I was able to finally find, with kudos to Peter Kafka, I actually did contact the Stony Brook out in Long Island. And Stony Brook, you know, when it was initially broached to me as a possible option, I'd say, I never heard of Stony Brook as being a possible cancer center, but I followed through and I got accepted into their trial for PSMA. And they are testing the 18F PYL injection, and it's Progenics who is one of the collaborators for this trial, which means that the cost involved is fully covered, as opposed to me having to go to California, UCLA or whatever, and spending a couple thousand, or even Sloan Kettering spending about possibly upwards of $7,000 for a PSMA scan. So that scan is also scheduled for the day before Christmas Eve on the 23rd. And the purpose of the trial specifically is to compare it against Axumin. And Progenics is, of course, very much interested in showing the world and the FDA that their injection is far superior. And so that's the point of the trial, and I'm very glad that I'm getting into it.
So the Axumin and the PSMA are both part of the Stony Brook trial, correct?
Right. The PSMA, Stony Brook will look at the Axumin results and compare it to their PSMA.
And Progenics, I'm not sure I know Progenics. I mean, we know Blue Earth for sure.
Yeah, I think Blue Earth is a gallium-68. I could be wrong, but
well, it's a PSMA. It's the PSMA binder. It's the PSMA. What they make is the agent. I always forget the right name. What's the right name for that, Mr. Geller, Dr. Geller? What's the right name for that PSMA agent thing that the two parts bind to? What do you call that?
Progenics was 18F. That's what I thought was different.
Oh, Progenics is the 18F one. Okay.
Right.
That's what I thought.
Yeah.
Yes.
I may be wrong. I mean, you can look it up.
But it's
No, you're
not,
correct. You're correct. It is.
Right, but it's not so much the 18F that's, because it could be 18F, it could be gallium-68. It's the bit in the middle that attracts the radiation on one end and the antigen on the surface on the other end. That's what's different in each one of these. So don't.
Right.
And anyway,
it's 1007.
okay, but I I want to come back on Carl because I've been thinking about this and it's been bothering me all week, Carl. Why are you so obsessed about getting scanned? I mean, what do you think the scanning is going to, what is the purpose? Because we always say, don't do a test unless you can respond to it. So what is it that you want out of this test?
I have reached the point in my treatment that my cancer is progressing. I am no longer responding to olaparib. My oncologist is suggesting that in order for him to determine the next course of treatment, that I should get a scan. So I was pursuing PSMA after hearing Len's story about his success with getting a PSMA scan, and they determined a viable course of treatment for him. And the people at Stony Brook said, well, you have to have an Axumin scan in order for us to...
I've got that part. But so what treatment do you think it will uncover for you? I mean, your doctor says he is going to help him determine treatment. What sort of treatment do you think it's going to uncover for you?
Well, I think that it can determine somewhere in the body that it could be a lymph node somewhere or some other location in the body that, like, for example, it could be a radiopharmaceutical type treatment, as Dr. Morgans have recommended to me, or it could be some other type of treatment, which we haven't discussed in detail.
Okay, so you're saying that maybe seeing the amount of metastasis may open up the option for Xofigo, radium-223. Is that what you're thinking, or are you thinking spot radiation?
It could be spot radiation if it was something that was specifically a spot, but it also could necessitate looking at other trials at Columbia Presbyterian, the BITE trial. Keytruda was mentioned to me as an option, so there were several things that are being thrown at me as possible treatment options going forward.
Right. So, I mean, I think about you as being systemic, and I don't see, I mean, you probably read what we said about treating oligometastatic disease and the concept of spot radiation being whack-a-mole unless it's used for palliative purposes, which isn't your situation. So if we're looking at systemic, and we know your situation is systemic, complicated by the BRCA mutation, it seems to me it doesn't really matter where these lesions are, because whatever you do, it's going to be some sort of systemic treatment. Now, it could be the radium-223. I personally would not do that because I don't think it's great technology, even though it's approved. And I think that the lutetium, when it does get approved, is sometime in the next 12 months, will be a much better option. Or I should say the PSMA-driven radionuclide treatment will be a better option, whatever it ends with. The other thing that sort of is staring at us is that you've never done chemotherapy. I mean, what are your thoughts on taking the plunge and doing chemotherapy?
I'm not opposed to that. That is something that also the oncologist has said that he wants to save that for whatever reason for a later time. Now, this might be that point, but our last discussion was that's how he described it to me, would be for a later time after several other treatment options.
I've said enough. Anybody else? Len, Peter, Herb, anybody else want to?
I just want to make a comment, Rick. Xofigo is not systemic. That's only for bone mets.
No, but
that would not affect any lymph nodes whatsoever.
That's not
That
true.
is that is true, but I still think of it as a systemic treatment because it goes to any place where there are bone mets. But you are absolutely right. I stand corrected, Jake. Thank you. So Jake's right. I mean, if you've got lymphatic disease, not sure how good the Zofigo is going to be. Anyone else want to add anything? Peter, your microphone's on.
Yeah, I mean, I tend to agree with Carl. I went through a similar thing, although I'm still hormone sensitive, but when I knew things were on the move, I wanted to know where they were. And was it, yes, it drove me toward chemotherapy, and it told me where the spread was, and it led me to another biopsy. And so for me, the PSMA scan was a useful tool. It set my mind at ease, knowing that I didn't have some other kind of cancer, that it was prostate cancer spread, and led to my next treatment course. So I can understand where Carl's coming from.
Okay. Are we moving on? Anyone else? Okay. Well, Carl, I think we're all really pleased that you found an option here, that we led you to a good option. And thank you, Peter, for doing that research that uncovered Stony Brook. It's huge for, obviously, for Carl and maybe for others that we'll send over there. And I hope it leads you to the right treatment, Carl. Len, your microphone's on. Did you want to say something?
I did. Thanks for noticing, Rick. I wanted to ask Carl, what were the PSA inclusion criteria for the Stony Brook PSMA PET scan? Was the lower threshold of PSA 0.2, 0.4, 0.6?
Yeah, 0.2. Yeah.
0.2. Wow, that's really low.
Yeah.
And what is your level?
1.1 right now and rising.
Okay. Yeah, I mean, another reason why this could be helpful, I think, for Carl is, for one thing, he would find out if whatever lesion he has, if it was PSMA avid. So, I mean, if nothing showed up with a PSMA scan, that would indicate that his lesions are not PSMA avid. And so none of the PSMA theranostics, as they call them, would be useful, like the lutetium or actinium or anything else that was PSMA targeted.
Okay, we will move on. I know that Regina wanted to talk about exercise last week, and we've spent quite a bit of time talking about exercise this week, Regina. Have we talked about it enough, or do you want to talk about it anymore?
What is the recommended amount of time per day that you should exercise? Raise your heart rate, that is.
Well, I mean, again, we're not docs nor are we exercise therapists, so we can't give you that sort of advice. What we can tell you is, first of all, you've got to work up to everything. So whatever the recommended time is, it's a question of how far you are into your exercise schedule. Secondly, we can tell you that you really do need to get your exercise up, your heart rate up, and if you're on hormone therapy, you need to mix it with some weight resistance. So it's got to be a combination of the two. Sometimes people do one day one day the other. I'll let the guys quickly tell you what some of their regimes are, especially the guys that have come from nothing and moved it on. But I always, when people ask me and they push me, I always say, you want to get that heart rate up for at least 10 to 15 minutes. provided, of course, you don't have any heart issues, to get the benefits. But again, I'd have to do some research and see what it said. Did you look at the research that I pointed you to last week on the MetaFit site?
I did. It wasn't that helpful in specific types of information that I was looking for. Like what kind of exercise does everybody benefit from? I've been doing exercise for an hour 3 times a week for 21 years and maintained my capability for walking. And
Right.
I don't have what you guys had. I had a brain bleed 21 years ago. And I was told I'd be in a wheelchair. Well, I fired the doctor. So I've been doing physical therapy-based exercise, which brings my heart rate up as far as it's possible. I've been trying to convince my partner to do the same, and it's been difficult.
All right, guys, go at it.
I'm coming.
Who, well, now we can hear Jimmy Greenfield. That's crazy. Okay, who wants to talk to Russell about how important exercise is and how much he should do? We've only got time for 2 of you, but come on, there's
Okay, the
so
only thing
many.
I can say is that I've been reading a lot about HIIT, high intensity interval training, that basically you don't need to get your heart rate up constantly that high, but you really got to push it up for intervals. And it's, at least the articles say it's more or less has the same benefit.
Yep, definitely. Yep, that's
Russell,
what I.
Yeah. Russell, do you have a friend other than Regina that you can exercise with regularly? Go out and walk with, or just meet with 3 times a week? That would help.
No, I don't at the moment.
Yeah, an exercise buddy would really help you if you could find one. Who else is a regular exercise? Oh, David, come on. I hope you step up to the plate here.
So one suggestion for you guys is I don't know if you can afford it, but it may be worthwhile to hire a personal trainer to get started, because you can really hurt yourself at first trying to do things that you don't know anything about, and if you haven't been training at all, you need to have somebody help you and guide you to get you started and get you into a routine. So just very hard just to run out and do something that you've watched YouTube, and you can end up hurting yourself. So be careful and see if you can find somebody to help guide you and help you get into a routine.
I would totally agree with that. Stay away from a gym if you haven't been going to a gym. You can definitely hurt yourself. Stretching before you do any kind of exercising is critical, and definitely get to David's point, if you can get a trainer, get started. That's really important. At our age, or typically our average age, you need to do it right. Otherwise, you're going to hurt yourself. As I did, by the way. But I'll withhold any more information about that.
Okay. I think we're going to have to move along, but you're free to raise it again. We'll try and address it again, Regina and Russ. But like I said before, it's the combination of both the weights at home, and there's been a lot of talk in the chat window today about using bands, using weights at home. If that works. Dr. Mark is a proponent of that. So the stuff that you can do at home, the issue is you just got to do it. You know, as Nike says, just do it. I'm going to keep pushing through so I can get to as many people as I can. Ben.
I'm going to hand my time back tonight. I'll catch you next week, next Monday.
Are you sure?
Don't ask.
Come on. Come on, you
I did.
hesitated too long. It wasn't, no, I don't care. Come on. You hesitated too long.
I got to talk fast like those guys on the Carly's commercials.
Yeah, that's it. Go on.
So I got a PSA 11 scan last week at MSK. It's still a trial there. I had to pay big bucks for it. And not unexpectedly, it found nothing because my PSA is only 0.2. What it did find, and the CT part of it, that I didn't even care about, it found nodules on my right lung that had increased in size that the pathologist thinks are metastases. But since they didn't light up, he thinks maybe they're not prostate cancer metastases. What I think is that because I have the ductal cancer, that it evaded the PSMA. There's some anecdotal evidence that PSMA is not a good test for ductal adenocarcinoma.
Yep. Yep.
So, but this was unexpected. I didn't expect it. Ductal also likes the lungs. It likes the viscera. But now I'm contemplating something I didn't expect to be contemplating so soon, which is Mets. And I don't know what happens next. I will talk to my doctor in a couple days. His intermediate advice is not to worry. Not as effective as I would like.
Yeah. So when you say your doc, you're talking about Boris Muller?
So this is the med-onc.
Oh, so which is?
Andrew Lassetti, Laccetti.
Stick that after we're done. Put that in the chat window for me, if you would. So it's interesting because I've been doing a little bit of reading on introductal recently, in the last couple of days, only because
this is not introductal.
Oh, it isn't.
This is ductal adenocarcinoma, which is not introductal. They're different.
Oh, okay. What I wanted to say to you is that we've known 2 or 3 people with lung nodules. And the best example is a fellow I was on a call with today with Bayer, who had surgery in 1999. And his cancer recurred in 2006. And he's still fighting it today and looks great. And he has had recurrent lung nodules right the way through. So even if they are lung nodules, I want you to know that they are treatable. And I'd be happy to put you in touch with this guy. He used to be the vice chair of us too. He's just a wonderful human being. I don't know, I don't have a lot of experience with ductal adenocarcinoma, but I think that your view is correct. Have you raised that with the GU Medoc?
I did, but it was, the PYL is supposed to be better. It was just, better than nothing. That was basically the thing. He figured there'd be a 2 out of 3 chance that the film would be blank, and that was indeed the case.
Yeah. Of course, the other option is to wait until you get into what was always traditionally the number until I just heard 0.2 is the 0.65 range, and where you're going to get a better result. And then the other option, of course, is for them to biopsy a nodule.
Is that as painful and awful as it sounds?
I don't think so. Herb's shaking his head. Herb, do you want to talk about that?
I didn't have a nodule, but I had a bone biopsy with a huge needle, and it was not so bad.
I had 3 nodules on the lungs, and they did a needle biopsy. They numbed the back and came in through the ribs, and it wasn't bad at all. It was a little bit uncomfortable. My doctor told me before we did it that it was a 90-95% chance because of the size, around 1 centimeter for the 3. They were most likely not malignant. Well, that wasn't the case. They were after the needle biopsy. So it was a clear path to the next step in treatment.
Thank you.
Thank you, Frank. I don't think you should be, how can I say that? You shouldn't be anything, I shouldn't say that. I don't know I would be that concerned about a biopsy procedure. The anesthetic's going to be there. They're doing it all the time. I think that's probably going to be what's going to give you the most peace of mind. Anybody else want to weigh in on this one?
I just want to appreciate that Rick insisted that you talk today, because this is a big thing, and it's obviously scaring the hell out of you. All of us know what it's like to get news that scares the hell out of us. So I'm awfully glad that you did speak today.
Thanks, John, and thanks, Rick.
Yeah, a pleasure. And come on, again, a quick plug. Rusty's probably left by now, but a quick plug that Speaking Freely on Thursday, and we would love to talk to you some more, Ben. That's the call that talks about everything other than treatment. So we talk about what you do when you get a diagnosis that scares the living what out of you. And we'd love to see you there. It's 8 o'clock Eastern in the Meniscus room, and everybody's welcome. Free drop in. David was on the call last month. It's a really good call, and we'd love to have you and help you talk some of this through. But we don't know what it is. We've got to find out, and I think that's probably the message for you to take back from today. And thank you, John.
Hey, Rick.
Yeah.
I just want to bring to Ben's attention, I dropped a link in the chat box of a case report, someone responding to ductal carcinoma of the prostate, responding well to docetaxel. I obviously haven't read the whole article, but that's a full text link there for Ben to just look at when he has a chance.
Great, thank you.
Yeah, just click on that link and it'll open up in your browser, Ben. You don't have to copy it. It'll open straight up in your browser. You can save it from there. Okay, David, I don't know. I don't think we're going to get through everybody. I'm sorry. Let's go to David. David, did you want time today? Can't remember. I thought you did, or not.
No, sir.
Oh, okay. Herb, you're up next.
Okay, just an update. Last week, I had my 3-month checkup for PSA, and it went down from 2.2 to 1.7.
Yay!
So that was very news that made me feel better. The only caveat was that they told me that NIH changed its assay, and so it's not directly comparable. And this one they think may be reading a little lower than the previous one, but nevertheless, I can't believe it's that far off. So just things are going in the right direction, and hopefully I won't get radiation cystitis from the radiation I'm going to get. That's it for today.
In January, right? Starting in January, Herb?
In January. Radiation will be in January.
Yeah, I mean, look, we've known people that have switched assays, and we sometimes tell people, if you're going to do that, try and get 2 tests, one with the old assay, one with the new assay. You aren't in a position to do that because it's not like you're going to different labs. But the difference we've seen is usually 0.2, 0.3, nothing more than that.
Right. I mean, somebody's got to run standards on these assays. It can't be that you just go in and then all of a sudden you just get a number. So, I mean, they've got to be validated or else they're worthless. So,
right. Anybody have any comments on, you know, different assays and the difference in tests, in levels?
Personally, this is Jake. I personally think, you know, they all say don't compare one to the other, but I also think it's a little bit parochial. They want you to stay with their lab and their test, because that's where the money is. So I agree. It's probably not that much of a difference between the ones, and it probably won't make a whole lot of difference over the long term. My 2 cents.
Thank you, Jake. Yeah, no, I'm glad you put them in, your 2 cents. All right. Anyone else on assays, different assays? Has anybody actually on this call done 2 different assays within a short period of time? And sees and known the difference? All right, in the interest of time, we're moving on to Dennis Correa.
Okay, I will be quick. Last week I had my annual physical with my GP, and they tested my B12 among the standard other panels of stuff they do. And lo and behold, it was low, significantly low. And when I looked up, you know, B12, what does it do for you? Well, if it's low, it can give you fatigue, it can give you brain fog issues, and what was the other one? I forgot now what it was. But anyhow, just something you might want to look at. I'm going to be taking, it's at the dose. I don't need an injection. I can do it with oral, 1,000 micrograms a day. Get the B12 back up, and maybe some of my fatigue will be gone.
David Muslin is showing us, he's advertising his brand. Were you low, David, or were you just...
Oh. Okay.
Okay. Oh,
That's the first I've heard. You know, the B12, I haven't heard, at least I don't remember hearing it, about B12 discussion here on this call.
I have a more important question, Dennis. You haven't reported to us for a long time on how you're doing on that drug holiday. Do you feel a difference? Are you feeling better?
With some things, it feels maybe a little better. But, you know, the other thing they checked was my testosterone, and it's at 10. So, you know, it's got a long way to go. And that's the primary thing that for all these other issues that you have, the weakness, you know, fatigue and muscle, brain fog and stuff that's related to that too. But yeah, August was my last Lupron shot. So I'm just past the 3 months, you know, September, October, November on that issue. And at the same time in August, I stopped the Lupron and the Abby and the prednisone, weaned off the prednisone for a period of 6 weeks at half the dose.
Right.
And I don't feel any different, to tell you the truth.
Is your PSA still undetectable?
Yeah, the GP actually checked the PSA in his test. It's a little different one. It came back at 0.06.
Okay.
Where my other test I normally get from the oncologist is less than 0.1. So they're both comparable.
Yeah.
So I think it's really short time, and I think it's going to take, you know, 6 months maybe before I think I really see any different.
All right. Now, my apologies to, I know there's a couple of people I didn't get to. We'll keep pushing until one of the ladies from the caregivers comes on the line, and then we'll have to kick them out and close the meeting. Dennis McGuire, I know you have something on your mind.
I do think one lady's here already, Rick. Pat Washburn.
Oh, yeah. Okay.
Yep, I will go ahead and leave.
You don't have to leave, Pat, because this is open to caregivers. You're very welcome to listen, but we will kick you. We're going to have to close the room in a minute and you'll have to come back in. But let's just, and Peter, I'm sorry we didn't get to you, Peter Kafka.
Okay, nothing important.
And John A, I apologize to you. We'll promote you next week. So let's just finish off with Dennis McGuire, and then Susan, hello.
Hi, I'll be back.
You'll be back, okay. Dennis, go ahead.
I met with my oncologist today, and I decided to stay on the trial another 4 weeks. And in 4 weeks, we're going to measure the PSA, and the goal is to get a response. If we don't have a response in 4 weeks, then I most likely will move off trial.
Okay, so you're not going to really discuss anything until you decide whether, and for 4 weeks. You're going to give it another 4 weeks, basically.
Yeah, I think we talked through options and the trial and how it's going, and I decided, he concurred that we should give it more time. I have 12 weeks invested in the trial, and I think another 4 weeks, and based on my staging, is acceptable.
Okay.
So Dennis, it's Ken, what did you find on your PSA?
It did go up. In the last month, it went from 35 to 42. Put in perspective, since I started trial, it has doubled, went from 20 to 42.
Yeah. And what about the bone and the CT scan? Did they?
Yeah, the CT scan, the same stubborn lymph nodes that I've had, primarily the 3 in the abdomen, in the 2 to 2.5 centimeter range. Those did increase on average 15%, 1.5.
Okay. Well, look, Dennis, if you want to talk about any of this stuff further, just pick up the phone, please. I'm sorry we can't give you more time today. As most of you know, this doesn't usually happen, but because of this calendar issue. But we'll be back on Monday, and we'll give you more time on Monday. We'll give John A some time. And I think we got through to, Peter will give, and Alan Moskowitz, I did see you come on, but as you see, we're so slammed with so many people that I just couldn't handle any more people today. But if you've got something, we'll for sure promote you next week. And Jimmy Greenfield, if he's here, I'm sorry, we couldn't hear you. I'll drop you guys lines. All right, we are closing the room. Yes.
Any time, and what time Monday?
8 o'clock Eastern.
Okay.
8 o'clock Eastern. It's back on the regular schedule, and there won't be any more screwy Tuesdays until we have another calendar glitch. And I haven't looked when that'll be. I think I'll get someone to look and see when the calendar glitch is in the whole of 2021. So we can plan them more. All right, guys. Sorry, I've got to close the room and restart it. For the next guys, I'll talk to you all very soon. Happy Hanukkah, everybody.
Be well, everybody.
Good night. Goodbye.
Take care.
Bye.
I love these men.